So I am Dr. Dragan Tesic. I am professor at University of Novi Sad. It is the north part of Serbia, at the Clinic of Endocrinology, Diabetes, and Metabolic Disorders. The title of my presentation is actually Diabetes mellitus as a risk factor in patients with ST-elevated myocardial infarction. So what was the background of this work? In the year 1960, so 3 years ago, we were surprised with the results of our patient, diabetic patient, when we analyzed the structure of their mortality. 80%, 81% of patients died from cardiovascular disease. And more further, 37% died suddenly. So these data are in great discrepancy with the data coming from developed countries. So what we wanted to do in this work, we just wanted to look at where is the place of random blood glucose, mostly the value of blood glucose when the patient was admitted to hospital, in patients with ST-elevated myocardial infarction. It was a classical case control study. Cases were patients who developed ventricular fibrillation during myocardial infarction. All job was done at Clinic of Cardiology. I'm thankful, very thankful to our colleagues cardiologists who accepted the collaboration between us endocrinologists and with them. And so all patients with ST-elevated myocardial infarction. A random blood glucose means that we dedicated our patient in different groups. If the value of random blood glucose, for example, when the patient was admitted to hospital, was 11.11 or more, we dedicated them as diabetic patients. And if the values were between 7.8 and 11 millimole per liter, these patients were with diagnosis of abnormal glucose regulation. We hope that we did not have any big biases. For example, at least 2 doctors at the admittance clinically examined the patients and indicated which class, KILIP class, was the patient. So the size of a study was dictated by the number of patients admitted to our hospital in 1 year period. It was in 2016 year. And if our data, quantitative data variables were not with normal distribution, we logarithmically transform and then performed calculations. So let me look onto this flow chart. Here it is shown that investigation, or when we recruited our patients, were 2016. In the year 2017, we followed the patients. In 2018 year, we calculated the data, and finally we are here with the results to present them to you. What was the differences and what were the characteristics of a STEMI patient with ventricular fibrillation comparing to simple, I could say, STEMI patients? Patients who developed ventricular fibrillation were younger. These patients did have more and more frequently diabetes mellitus. The value of this random blood glucose value in patients who developed ventricular fibrillation comparing to those who didn't develop was in the range of diabetes mellitus. So the average value is 11 millimole per liter. Finally, most frequently, patients did have developed at admittance KILIP 2 class, meaning a late inspiratory crackles at the admittance. And finally, the most frequent location of myocardial infarction was anterior and lateral wall. Then when we admitted the patient, or cardiologist admitted the patient, the finding on coronography was most frequently affected or culprit artery infarction was left anterior descendant artery, and most frequent location of the thrombosis in affected artery was proximal occlusion. Ejection fraction was lower in patient who was admitted, as STEMI infarction with ventricular fibrillation, and there was a higher mortality rate, significantly higher mortality among the patients with ventricular fibrillation. Then, after 1 year, what were the results of our patient after 1 year? Comparing those who in the meantime died and those who are still alive. Patients who died were older, 70 years old. It was at least 6 years shorter age time period than it is expected. What is very important data is that patient delay to refer to first medical center or emergency system was significantly lower period, just telling us that each minute is important for the future prognosis of such a kind of a patients. Ejection fraction was lower. KILIP class 3 was the most frequent among those who died. And again, diabetes mellitus was at very high, with the very high prevalence, 68%. So just to repeat, diabetes mellitus was present in more than 50% of patients who developed ventricular fibrillation, and in 68% who died in the meantime on 1 year period. So, to conclude, I will actually present the highest statistic we performed. It is the modeling. The major risk factors associated with elevated myocardium who develop ventricular fibrillation was proximal coronary artery occlusion plus diabetes mellitus. The factors that were associated with mortality in patients followed 1 year after their elevated myocardial infarction were KILIP class 3, meaning pulmonary edema, low ejection fraction, again diabetes mellitus. When we included into the calculation also the age, the major risk factor associated with mortality was patient delay to refer to reference medical center. KILIP class 3, age, and diabetes mellitus. And final conclusion, in all these, I could say, severe ischemic group, and those we presume were with low patient with cardiomyopathy, in all of this group, diabetes mellitus was the most prominent risk factor. Thank you for your attention.